from the EPDC Council. I'm here to introduce our Grand Round speaker. Dr. Alan I. Frankel is an internal medical doctor and one of the world's leading authorities on dose cannabis medicine. With over 41 years of experience in internal medicine, Dr. Frankel applies his knowledge of all aspects of the cannabis plant and its therapeutic value to the treatment of multiple serious medical conditions. Dr. Frankel has presented multiple CME accredited Grand Rounds lectures on internal medicine and therapies in medical cannabis. He has also participated in roundtable discussions on the topic of future therapies and research for medical cannabis sponsored by the California Medical Association and the Los Angeles County Medical Association. In addition to graduating second in his class from the UCLA School of Medicine, he was elected to the Alpha Omega Alpha Medical Honor Society. For 3 years, Dr. Frankel was selected by his peers as one of LA Magazine's top internists, and he was a clinical professor at the University of California, Los Angeles School of Medicine for 18 years. The Chartscape medical software program used by the UCLA Bauer Cancer Center and the eScript medical software utilized by Kaiser Permanente healthcare systems were both developed by Dr. Frankel. He is also the founder of Green Life Docs and is the CEO of Greenbridge Medical Services, Inc. His card is on the back table and some information if you guys would like to take any. So please help me in welcoming Dr. Frankel.
A few of these are new slides, so I'm trying on you guys for the first time, so I hope they'll work well. 13 years ago, I decided I was going to make a change from my full-time internal medicine practice to cannabis. I had had an illness, which I think cannabis did help me with, and it got me, but what it did, it got me studying and reading, and there are a lot of studies out there, and we certainly need a lot more. But even 13 years ago, there was good information. What there wasn't was any medicine that I would call medicine, because if it's in weed form, if it's in undosed form, how do you have a doctor-patient relationship when neither the patient nor the doctor know what they're taking? So it took 5-6 years to start getting labs set up and starting to dose medicine, have consistent medicine, and that's what ultimately over another 8-9 years led to this talk. So cannabis and pediatrics, most of this is going to be more of a general talk, and then I picked 3 or 4 specific things. Seizures, which I knew you'd be interested in, and it's becoming bigger and bigger and more interesting. Autism, and a couple other things. That's basically me. Yeah, at one point in my life, I couldn't decide when I was a UCLA undergrad whether I was going to go into technology or medicine. So I was doing both, but punch cards got me out of it, and I decided to go to medical school. But actually, it helped a lot when I got into cannabis, because everything was being done by phone and paper, and we needed systems. So about you, can you recommend cannabis to your patients? What is a legal requirement? Is there any required training? The Ninth Federal Court, what is the risk with the medical board? Had I asked these questions of you guys 10 years ago, or just over 9 years ago, I was just starting on my first probation. So it was quite an experience. Lost my license for a number of years, sued the medical board, got my license back, and it was all, I mean, we all do some hand slaps up, but it was all cannabis. But the times are different now, and the doctors that are interested in using cannabis for their patients are here. They're not in the clinic just writing, slips of paper. So what can you guys do if you're interested? Assuming Children's Hospital is okay with it, you can write recommendations. You can give dosing information. You can follow up with the patients, and you can learn from this information we put out, talks like this, and I have doctors in my office from time to time spending a week or 2 weeks and getting trained. So I definitely want to train more doctors. The third point here, the Conant decision, the Ninth Federal Court, is fascinating. This was in the early 2000s, and I don't know how or why this got passed, but this changed all of medical cannabis because it scared doctors from doing any dosing or making any specific recommendations. And the law stated the doctor may recommend cannabis, but he or she may not give any dosing or other detailed information. Well, that became a huge deal back in 2007 and 2008, and I was actually pushed aside by a number of the cannabis doctors because I insisted upon dosing. I did not believe that the DEA or the FDA would come to LA and arrest me and go to a federal court, accuse me of dosing and giving information to patients. It just didn't make sense that it could happen. So very, very, very few doctors in the country did it. And I mean, it's been fantastic. So I would encourage you people to consider it. All right, so to take it to 30,000 feet, I kind of made up a cannabis organizational chart. And we have, you guys see the red? Yeah. So these are exocannabinoids and these are endocannabinoids. Exocannabinoids include whole plant cannabis, which is the one you're most familiar with, hemp, which hemp has now changed. It's now defined as any cannabis sativa genus plant that has a THC of 0.3 or less. So now, as much as I not really like hemp-based medicine because it's just CBD, it doesn't have all the richness of all the terpenes and flavonoids and hundreds of molecules, the next version of hemp is going to be what I call hemp version 2, and so it's going to be very confusing. That medicine will be as good as, it'll be the same as a cannabis medicine. So on the exocannabinoids, oops. Right, so the whole plant cannabis, which is your regular smelling cannabis plant, hemp, which is now going through a change in definition, and labmate. Labmate is single molecule CBD, single molecule THC, and the industry is going towards isolates and distillates, and to me, it all seems crazy, certainly for medical cannabis. We have a plant that's evolved over about 100,000 years, and there have been 1,000 molecules that have been identified in cannabis. An average plant has 700 unique molecules. It doesn't make sense to remove those unless you're a pharmaceutical company and you can only have 1 or 2 molecules in your medicine. So that's where the whole problem is. So then going down from hemp, you've got fiber hemp, which is most of where CBD and all the vet CBD and all the stores where you see CBD being sold, it's virtually all fiber hemp, and it's not very effective. Hemp version 2 will be the same as cannabis, except it'll be low THC. And then isolates and distillates we talked about, and what they're basically doing is stripping, like Epidiolex. Epidiolex, which we'll talk about later, is 1 molecule. And they started with whole plant. They just threw away everything else. So the key players. We have plant-derived cannabinoids and we have endogenous cannabinoids. How many people here have heard of the endocannabinoid system? Yeah, but you've been working with me for 10 years. Just like we've got the plant molecules, THC, it starts in the plant as the acid form, THCA, CBDA, and the acid is this part here. When you heat it, it decarbs. This goes off as carbon dioxide, goes off as carbon dioxide and every cannabinoid. This is tricky. Well, I'll just use my finger. And then when you heat it, the CO2 goes away and you have THC, or the CBDA loses CO2 and becomes CBD. And up until 4 years ago, there was no information at all on the acid molecules, so we kind of thought they were just precursors and they weren't important. They're just as important. And man's been eating this stuff for 100,000 years. Probably longer because we got fire 100,000 years ago. And then here we have the endogenous cannabinoids. We have, and this was discovered in 1985, Dr. Meshulam in Israel was trying to figure out where does THC and CBD, which were discovered in the mid-60s by him, where do they act? What receptors do they act on? And in the quest for that, they discovered that we have a gigantic endocannabinoid system that affects every cell in our body, and that's how one of the mechanisms where cannabis works for cancer. But when you have patients coming in, for example, with anxiety, disrupted sleep, migraines, fibromyalgia, and often chronic pain, and you think, do I have 5 diseases? No, that's what's now called it's kind of a funny term, endocannabinoid deficiency, meaning that we don't have enough pot, right? But they call it the tone, but it's actually the levels of these very specific endocannabinoid molecules that we can now measure not just in the CSF, but now we're able to measure them in the blood. So, I mean, to me, the future of where this is, I'm not following the slides exactly, but the future of this is going to be getting like blood levels on CBD. For example, you guys start somebody in Epidiolex and you're trying to decide doses. What's the therapeutic dose for CBD for seizures? I don't know. I think we should start figuring that out. So there's a lot to learn, but the main takeaway from this slide is, I mean, the rings aren't as, they're open here, but you can see these are all very similar molecules. All right, the main point, the 2 points of this slide. One, the cannabinoid receptors break down into probably hundreds of receptors, but the ones that we talk about now are CB1 and CB2. And these receptors, the central nervous system and the peripheral nervous system are richer in CB1 and our lymphatics and our gastrointestinal tract, and now we're finding CB2 receptors in a lot of other places. But the most interesting thing to me about this slide, it reminds me, here's the brainstem, right? There are very few receptors in the brainstem for cannabis. That is the reason there can be no deaths, because those boring tasks like controlling blood pressure and pulse and respirations, brainstem's pretty important. And if you have narcotics and benzos that are going to have tremendous effects, you can die. You can't die with cannabis unless 1,000 pounds lands on your head. There was a supposed death in Amsterdam 2 years ago, but this guy, I don't know if he was stoned and drunk or what it was, but he ran into a train and died. I don't think that's a real cannabis death. That's stupid. All right, so here are the CB1 and CB2 receptors you just talked on, and think CB1 is going to be central and peripheral, and CB2 immune, but now this slide's a little bit too old, needs to be updated. The gut has tremendous numbers of receptors, and that's why we get responsive inflammatory bowel disease and other GI issues. And, irritable bowel is so simple to treat with cannabis. All right, so the endocannabinoid system, hundreds more receptors. Anandamide is the THC-like functioning one. 2-AG is the CBD-like functioning one. So before I finish this one, I'm willing to bet that everybody in this room has done the following. You've taken at least once in your life a lemon and smelled it deeply, and then even smelled it a second time, and there aren't very many other things you do that to. So if you're wondering why, it's because one of the terpenes in lemons is limonene. And limonene hits a little hit at the CB1 receptor. So it's like a tiny, 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 tiny dose of THC. So it makes us feel just a little bit higher. I mean, I used to think that essential oils were silly, and now I think they're what really makes us move. A school that I'm aware of in the United States that's teaching the endocannabinoid system, which is 35 years old now, and which is being studied by pharmaceutical companies at universities all over the world. And what they're attempting to do is make, instead of having like CBD and THC or CBD and THC-like molecules, they're looking for pharmaceutical endocannabinoid-based therapies. So let me just very briefly tell you the first 2 stories of what happened with drugs that were meant to, they don't look anything like CBD or THC. These are meant to interact with the endocannabinoid system. The first one was Ramonabond in 2009, and I don't remember what company was making it, but it was designed as a weight loss drug because it blocked the CB1 receptor, which blocks your appetite. A number of us, about 9 doctors, we wrote a letter to the company telling them that we were terrified what they were doing because there's also, if you block your CB1 receptor, you get horribly depressed and a lot of other things. So the study ended up with a number of suicides and psych admissions, and that was the end of rimonabant. 4 years ago, there was a French drug, which I don't remember the name of. There were no animal studies done on this drug. They gave it to 2 or 3 patients who had brain death. Brain death. I mean, that's missing the mark by, quite a bit. And that tells us how incredibly complex the system is. And the fact they're not teaching in medical school is horrible. I mean, just to know that irritable bowel and migraines and anxiety are all related, and you can actually treat them pretty successfully with just a little CBD, beat 5 pharmaceuticals, and that's obviously why they're not being taught in medical school. All right, this is one of my favorite slides. You've got the presynaptic neuron going to the postsynaptic neuron. And what we're used to, what we were taught in school, is it's released here, and it has its effect here, and then an action. Well, here, think of these neurotransmitters as dopamine, serotonin, norepinephrine, all of these. And those are made and stored and released. So let's say dopamine is coming across this synapse, walked away. The precursors for anandamide and 2-AG are made on the fly, depending upon the rate of the transfer of these neurotransmitters, and feeds backwards, retrograde, through the synapse, stimulates the CB1 receptor, which then can increase or decrease the amount of the neurotransmitter that's going across the synapse. And that is actually a summary of how cannabis works in general. It doesn't increase immunity or decrease immunity. It doesn't increase inflammation or decrease inflammation. It modulates it. It tries to get everything towards the middle. And I mean, on the fly to make, it's incredible to on the fly make something that can feed back on something that's being transmitted in real time, I think is very cool. Benefits of the major cannabinoids. I think I'll just leave it up here. A couple interesting. Antibacterial. The most interesting to me bacterial issue with CBD is it's an incredible killer of MRSA. And I've tried at several hospitals to even get CBD to put into the cleaning fluid in the OR. And why not? I would spray it to rooms. MRSA is a problem. And I actually made a plate a few years ago over at, I won't say which hospital. And it was scary playing around with MRSA, but the kill zone was just incredible at the low dose. And I think the next area, antibiotics, is going to be plant-based, because we're running out, as you know. Neuroprotective is a big one. There's more and more evidence that both CBD and THC can help protect the brain from advancing Alzheimer's or other, dementia. It's a vasorelaxant. You see patients having to stop their blood pressure medicines. I had to stop my blood pressure medicine. My blood pressure went down to like 90/60 on CBD, and I was getting lightheaded. Anti-epileptic we'll talk about. Anti-proliferative, that's cancer, and we will talk a little bit about that. And there's a lot of new data on psoriasis, both topically and systemically. The entourage effect really is, we've talked about a little bit already. If you have a one molecule, you have very limited effects. There's hundreds and hundreds of molecules. The terpenes are the scent molecules, the flavonoids are the taste, but it's not the taste itself, it's what that does, what actions that take. And there's waxes and lipids, and again, over 1,000 molecules found. I think at the end of the day, if you look at this plant, it's a vegetable, and when you squeeze it, vegetable oil comes out, and the vegetable oil dose is then the medicine. This is vegetable oil. We need to look at it as vegetable oil. It's a supplement. Reference again quickly to the endocannabinoid deficiency syndrome. But fibromyalgia, using CBD during the daytime and a little THC added to it at night, it's no longer a disease that I dread when they come in. And when they come in with all of these things, we used to, they've got to be messed up, they're stressed out, they're depressed, they're anxious. or they have an endocannabinoid deficiency. Cannabis as a supplement, I think, is a big deal in the future. And one of the fascinating things with dosing of CBD, if it's a cancer patient or a seizure patient, you're not going to just willy-nilly decrease doses. But if it's an anxiety patient, pain patient, insomnia patient, when you see them 6 months later, almost always they're taking less. So the dose of CBD just decreases over time. Why? I mean, I've never read any reason why. My two theories are either A, it's treating nutritional deficiency, and it treats it like treating vitamin C for scurvy, and then you don't need extra stuff anymore. Or we know that it ramps up our internal cannabinoids, our endocannabinoid system, and maybe once they're ramped up, we need less. Generally, with most medications we take, like the cortisol, it suppresses our adrenal. Estrogen, it suppresses our ovary. Testosterone, it suppresses testicular function. This is one of the few areas where it actually increases it.
I have a quick question. It wouldn't, by taking it, it wouldn't make the body produce less of it, like certain things you take, and like for instance testosterone, the body's like, well, why produce it? I'm already getting it externally. Why does this not have that same effect?
Well, it has a better effect. Its effect is it's increasing our own ability to make it, and then we take less.
I see.
Anti-inflammatory, antispasmodic, and the antispasmodic is everything from coronaries to skeletal muscles, to smooth muscles, to gut muscle. Mitochondrial modulation. I think the THCA, the raw form of THCA, plays, and there's not really good proof for this, there's just so much clinical evidence that we've been seeing in the last, like with myasthenia gravis. I mean, who would think that a combination of 3 cannabinoid molecules, you get most people off their steroids and their methadone, that's unbelievable. And mitochondrial modulation, I think part of the thing with myasthenia is through the mitochondria, and we have all these mitochondrial myopathies. I'm sure you guys see more than I do in peds, that THCA and possibly CBD are going to be really effective for that. Cannabis is a P450 system. As a general rule, if you're using whole plant cannabis, this wouldn't apply to Epidiolex since it's a single molecule. But whole plant, at doses up to 40 milligrams, there is just no P450 issue. When CBD is part of the whole plant, is absorbed, goes through the duodenum and then into the liver, the CBD is aware of the endocannabinoid system, and using the word aware, and it sends a signal to the liver to increase the number of P450 enzymes. So it's like inviting somebody over for lunch and you're worried about the food, but they bring their own food. So whole plant cannabis and drug interactions when you take orally is not a big problem at 40 milligrams or below. What I get concerned about is when you're having isolates like Epidiolex, your average dose is going to be 400 milligrams, the daily dose. But we'll be getting into that a little.
What is the P450 system?
The P450 is the liver system that metabolizes drugs.
Okay.
And we've seen almost 500 seizure kids, and they're all getting blood tests. And we've not seen problems with their epileptics. All right, so these are wrapping up. Just to very quickly go through these, I guess, 5 pediatric conditions. Glioblastoma, astrocytoma is by far the most I see. The changes in that in the years we've been doing this treatment is dramatic. I listed some studies here, and I'm sure you guys will get this posted. That's a real deal. There's one study that was finally published about 8 or 10 months ago, where it was Temidor and radiation, or Temidor radiation and cannabis. And by the time they finished getting into the 3rd phase of the trial, they had to stop it because the group that was getting the cannabis was doing so much better. So for glioblastomas, astrocytomas, there's actually good data on it. And we're going to be seeing more and more good data on it. But that's just treating the tumor. The outcomes are beginning to show more and more that it's effective. But there's other things to consider. A lot of chemotherapy causes neuropathy, and I work with a number of oncologists now because at varying doses of CBD, you can prevent the neuropathy. And with another, actually transdermal cream, there's about a 70 to 80% success rate getting rid of the neuropathy. And I think THCV is going to be shown to be nutrition for the myelin sheath. This also has some really some optimistic stuff going on with multiple sclerosis. So reversing neuropathy, preventing neuropathy, dosing, it's getting more and more complicated as we find more and more molecules and oils that are effective against cancer. These don't make people sick. This is just cannabis. We add them. Here's what I meant to get a second example because these actually came in about the same week. This was a 19-year-old who had video guy here? Where's that? Oh, great. So the cancer, this patient had surgery, had chemo, and radiation, failed everything, and over the last year been on cannabis. And there's still, I think, a little tumor left, but this is pretty impressive. Pardon me?
How long has it been?
About a year. Usually see response in about 3 months. Cannabis and seizures. Right, there are a lot of molecules that are effective for treating seizures. CBD, we know the best. We're already using a lot of THCA for seizures when CBD, isn't effective. But CBG, THCV, CBDV, I put CBG twice. There are a lot of other molecules, not just CBD. And we're gonna have a lot of decisions in, do we send a seizure patient or treat them with Epidiolex? And one good reason would be it's covered by their insurance, that helps them a lot. The efficacy, I think there's already some studies by Dr. Chumrit Sivani in Israel that one, there's tolerance with Epidiolex, and the complex plant extracts don't have tolerance. You don't need to keep increasing the dose. And it's about a 30% tolerance rate. But another study by the same group in Israel showed that a single molecule of Epidiolex had about a 35-40% success rate at suppressing seizures more than 70%, and whole plant was up in the 65 to 70%. Whole plant works better. I mean, it shouldn't be a surprise to anybody. And the article is posted there. Autistic spectrum. I'd say that my initial experience was overwhelming. This was 7, 8 years ago. I didn't know anything about CBD. I didn't know anything about autism. And a kid came in with autism. He might have had seizures on top of it. So I was totally overwhelmed, stopped doing it. Started learning about autism, started learning about CBD. And now these kids are my favorite patients. I love them. The visit always starts in the waiting room. So these kids, if you can make them think in the waiting room that they're at a fun place and they're not going to a doctor's office, all of a sudden they're like they're home, and they come sit on my lap, sit on the floor. And does this help brain function? I don't know. What it does, there are some kids, maybe it's because we're reducing their anxiety so much that they're able to learn. But the kids with seizures, if they're having 100 seizures a day, 150 seizures a day, or 2 seizures a day, how do they learn as much? Because their memory is. So I think there's a number of reasons why these kids get better. The toughest ones, and these are the ones I'm seeing the most now, are the autistic kids who are really violent and biting and kicking and getting thrown out of school because of that. CBD doesn't help with that. THC helps with that. So over the last 3-4 years, we're getting more and more comfortable using THC with the kids, and they tolerate it unbelievably well. I mean, if I had to treat, and let me make one point very clear. I do not think children should be using, or minors should be using cannabis if they don't have an illness to treat it. I mean, I think they shouldn't be using any medicine. But we see a lot of sick patients, and either the medicine's not working or they're having terrible side effects from it. To me, this has been around a really long time. I think it's safer than most of the other medications we give people, without any doubt. So the child's outbursts in THC is an important takeaway. Cannabis hyperemesis syndrome. How many people in here are clinical people? Oh, have you seen any hyperemesis patients yet? Right, you will. The cannabis hyperemesis is caused, usually it's a young male. I've seen a couple of women with it, but it's usually the guy, 17, 18, 19 years old, that's dabbing oil. He's taking a huge dose of oil. I mean, the rig that they use for this makes it look like you're really using bad drugs. And it's just not a good thing to do. And what happens is there's some change, either downregulation of the CB1 receptor or something with the TRPV1 receptors that changes, and these people get this emesis syndrome where they get abdominal pain, diarrhea, and tremendous vomiting. And the only thing that stops those symptoms is more THC or a hot bath. And the hot bath, the heat, gave somebody the idea to try capsaicin. And there's now, if you look up capsaicin and hyperemesis syndrome, in a number of ERs now, they've had some observational clinical trials by just rubbing some 0.1% capsaicin into the lower abdomen. It stops it within 20, 30 minutes. And capsaicin works through the TRPV1 receptors on pain fibers. So that's one theory. But be sure to think about it, the kid, because what happens with these teenagers is they get sent to a ton of GI docs and get tons of workups, and then they go sneak, get some weed, and you can't not talk about it because it has to be talked about. ADHD and anxiety. I never felt this before I started working with these dose medicines, but at least from a cannabis perspective, ADHD and anxiety are the same disorder. And perhaps a third of the kids that come in with this are already taking a benzo or Adderall, Strattera, or one of the other stimulants. And I mean, to me, there's a really good example. If you're okay with giving somebody a stimulant and you're not okay with CBD, you need to start reading more. Because how is it possible that speed is safer than CBD? There have been lots of deaths with speed. I mean, I can write a triplicate prescription for methamphetamine tablets. I mean, that's still available by prescription. Oh, and for additional information. Questions?
When these people are ingesting the CBD, what is their affect? A lot of people know what it's like if they smoke, but what's it like when they take it in their gut?
Well, if they take CBD, I mean, the most common way we do it is sublingually. We do it also orally with capsules. It's a very different feeling than THC. The only side effects, and I tell every patient this, the two side effects of CBD are weight loss. If people are heavy, they lose weight. They really lose weight, and it's a metabolic change and an appetite change. And the other side effect is hyper calm for 3 or 4 days, because usually the people are tired and they're fatigued, and they take some CBD, which is not sedating, but it's very calming, and they fall asleep. And I tell them that's a side effect only so that they won't worry that it's a problem. But within a few days of taking CBD, all you feel is better.
Okay, so what about the patient who might have a irritable bowel syndrome and low weight? And weight loss would be a problem then.
No, well, the weight loss only happens if the person is overweight. Yeah, and for irritable bowel, the irritable bowel patients mostly gain weight. Or let's say you've got somebody with anxiety and you give them CBD and they're underweight. They'll gain weight because their anxiety is a common cause of suppressing their appetite. They feel like just a little queasy. So they feel better with CBD and they eat. I mean, pretty much all the cannabinoids have in common anti-nausea and anti-cancer effects and anti-pain. I mean, virtually every one, and then even if you're looking at the terpenes. And I think the reason for that is this was co-evolving alongside man, and we 100,000 years ago, 125,000 years ago, had these plants, and we picked them. We didn't have anything else to do. So we'd pick them and see what happened, and they would have things like pain. They would have things like cancer. They would have things like mood disorders. I imagine pain was a really big deal back then. Now medicine has taken over. We're the big cause of pain.
So with the sleeping, does that cause any lack of function because they're sleeping too many hours or in inappropriate times?
Well, that hypercom that I was talking about only lasts for a few days. Then people have a couple good night's sleeps and they're fine. I've never had. There are occasional cases where people will complain that CBD is making them a little sleepy, but that's pretty uncommon, and it's usually just in the very, very beginning as they're adapting to it.
So now, you talked about these prescriptions that insurances will cover. What's the cost to the patient for CBD? How do they get that, and what does it cost?
Well, first I don't sell it. I'm not a
Right.
doctor. I did a calculation comparing. I was just curious, Epidiolex versus whole plant cannabis. But if insurance is covering it, then it's a completely different deal, and that's certainly the best reason to consider using Epidiolex instead of CBD. Most of the neurologists don't know that the dose of Epidiolex is 4 to 5 times higher than the whole plant. So when they see my patients and they're on 80, 90 milligrams of whole plant CBD, they think, well, no, he needs to be on 400. But it's a different medicine. It's a different medicine.
For let's say cancer patients, they're just getting cannabis to smoke or whatever. Does it have the same effects if it's not dosed, like anti-proliferative?
Personally, I mean, I'm fine with if anybody wants to smoke cannabis, and whether it helps them with some symptom or they just enjoy it, I don't have an issue with that. But I never am dealing with that in my patients. I probably have out of thousands of patients, I probably have a half dozen or so that actually smoke. I don't even know why they can still come and see me, because there's really not much I can. This whole thing about strain names and sativa and indica, they don't mean anything any longer. And you'll hear this from your patients. It used to be in the past that the sativas, as a rule, were more upbeat. They were the daytime strains, and indicas were in the couch, more nighttime strains. But now it's people will feel strongly that indicas are for them and sativas are for them. But what determines whether something's, I mean, if you go into the store and you happen to know what you're looking for, they're all the main thing that determines whether something's a sativa or an indica is how long it takes to flower. And sativas have a very long flowering time. Growers didn't want that. It costs a lot more money. So they bred them with other plants that have a shorter flowering time. And that's why pretty much everything is, by those terms, an indica. I just think those terms are past their prime. We don't need to use them anymore. And things are based upon what the molecules are inside the medicine and how much is absorbed, and which is a big problem. Let's say somebody comes in with some illness and I give them a cannabis regimen that I expect will help them, and we're tuning it up, and they're just not getting better. Either I'm just on the wrong track, definitely could be the case. Or what if they didn't absorb it? Cannabis absorption is a real problem. I mean, oral absorption is in the range of 20% of the milligrams will be absorbed, into the small bowel. With sublingual preparation is maybe 30%. Rectal, which people say is the best way to do it, there's no absorption. Oil is not absorbed from the rectum. We're working on some ways of adding an excipient to allow it to get in, because it then might be an interesting treatment for rectal cancer or prostate cancer. But we did it was very simple studies, and other people have done them too, where you give somebody a 100 milligrams suppository and then you check their blood levels. And we need to start doing that as part of clinical care.
Version of tropical, like a patch, like a nicotine patch.
It's the same issue, because unless you know what percent is absorbed for that person and what finally, we need to know the pharmacodynamics of every medicine that we're using, and we don't know. That's the problem. We get away with a lot because it's so safe, but we'll go, we started here, we're like here now, and once we can get these lab tests done and learn more about the pharmacokinetics, not of a pharmaceutical version of a product, but of what people are actually using. That's where we're way behind. I would love to have a lab machine that I could measure people's blood. It would be a big help.
I know adults with cancer who have like nausea, vomiting, they'll smoke cannabis for helping the nausea. And I just remember from personal experience way back when that just how quickly that works. How does the CBD oil compare, or how would that transfer to pediatric patients? If that is really honestly the best method to get it in, do they have vaporizers? Do they have ways to suck it out of the room so it's not floating down the hall? I don't know, that's what I think a lot of red flags go up to the hospital.
I still get asked this question, which I find hysterical. How do you get the kids to learn how to inhale? And I said, you're right, the exhaling was pretty natural, but the inhaling took a lot of work. Obviously, we're not giving kids smoked or vape cannabis. The main way it's done 95% of the time is oral buccally or sublingually.
Okay.
It's pretty, yeah.
Does that work as quickly as through the lungs?
No.
So why is it okay for adults to get that quick relief, but kids have to suffer?
Well, it's not that they have to suffer. It's just that first of all, let's say let's say you could teach them to inhale, right? the dose that you can give them is pretty tiny per hit, and the hit only lasts an hour. That's it. So you have to be giving it to them, and their levels would be going like this, and they'd be having breakthrough seizures all the time. Sublingually, or kids with autism don't swallow capsules. So far I have not met one autistic kid who can swallow capsules. So either we're doing it under the tongue as best the mom or dad or caregiver can, or buccally. And more often I'm telling them to take, let's say it's a milliliter of 20 milligrams of CBD, to take that, mix it in with a little fatty yogurt, like Greek yogurt, or pudding, or something with fat in it. And then some of it will go GI and some of it will get absorbed locally. But transdermal has a big future. We're doing a lot of work on that. One of the advantages of transdermal is it's a quick onset, 10 to 15 minutes, you start getting effects, and prolonged action. And that's why they're using estrogen and progesterone in the quicker things. So look for those types of products. They'll be out soon.
I work with a patient population that has a lot of chronic and neuropathic pain from their disease. What are the...
Well, other than having 3 children myself that are happy and married and successful, and having 7 grandchildren, and that happiness and pleasure, the only thing that comes close to it is what we've done in the last year and a half with neuropathy. If you're talking about tinctures with neuropathy, you get some relief. You definitely, with a 50-50 CBD, THC, that's what the GW pharmaceutical company found to be the best, and it definitely works. But it doesn't work great. What works great is actually THCV in different preparations. I mean, I'm treating a number of people in the office with it, and it was like one of those diseases that neuropathy is horrible. I mean, this is suicide pain. And you had two elderly ladies who didn't have as much pain as they just didn't feel anything left. The pain had kind of burnt out, so they were wheelchair bound and put some of the cream on it in the office. And by the time they left, they walked out. So there were two patients like that. But we did a study, just an observational study in the office of, about 80 people, 70, 80
Yes.
patients. And over 2/3 had dramatic responses. And the responses come on usually the first day, usually the first hour.
Have you ever worked with any patients with sickle cell disease?
No.
That's the patient population I'm talking about. So we have a big issue in our clinic, especially with some of our adolescent young adults who develop chronic and neuropathic pain from chronic use of opioids over many years. And I personally have several patients right now, and
They're in agony.
yeah. I mean, they're using a lot of short-acting opioids, and there's just not a lot out there.
We've done a lot of work with replacing opiates with cannabis. I think that's going to be, it's such an obvious answer to or part of the answer to this huge problem we have in this country. And I've met with, I don't know, probably 6 or 7 different rehab centers. They're all very interested, and somehow they just go away. They don't know if they get scared, but I'm certain that we can do a lot of narcotic work there, a lot of narcotic work with cannabis. I mean, we're doing a ton of it. I mean, the cancer patients, I mean, that's different than an opiate addict who's on the street. That's a different situation. But, and those are going to be hard to treat just because of compliance. But if you have a patient who wants to get better, it's not that hard to get people off narcotics the vast majority of the time. So, oh, that's it.
Alright, what's the, I just have a question then, is there any groups in California or in the nation that are working on like lobbying or anything like, so insurance companies will pay for these products?
About 4 months ago, there was an article in the New York Times, and there was something on TV that followed the story. And it was in New Mexico, the state Senate and Congress were voting on whether insurance companies could reimburse for cannabis. And at the state capitol, there were some people from the insurance company and people from pharma. So fortunately, New Mexico, they voted, their state Congress voted to allow insurance companies to pay for cannabis. That was a huge deal. Then they interviewed the insurance man and the guy who represented the insurance company, and they asked him, why are you guys pro-cannabis? And he said, that's going to save us a lot of money. They know that, and once I think it's going to be a while before insurance companies, and they're not going to be reimbursing it when it's Schedule 1. I don't see that happening. But I do think the Schedule 1 is going to change. And part of the reason it's going to change is because of the insurance companies. A few years ago, I was speaking at a conference in Europe, and a doctor who worked for a pharmaceutical company came up to me and said, we enjoyed your talk, but we think you're cheating. And I said, well, I'm probably cheating in a lot of areas. Which one are you talking about? And he said, you're using whole plant. And then he smiled, and we went to lunch together. And with pharmaceutical companies, a number of people, they're not stupid. They may be greedy and mean and really difficult, but they know that cannabis is a big deal. I mean, I've had most of the medical, I think probably all the medical board issues that I had in the past were through pharma. When I visit my probation officer, there were pharma little handouts on his desk. But my probation officers ended up referring patients to me. So there are some good, actually some good people on the medical board. There was one really bad one though. But I would just, if you're treating your own patients that you're seeing on a regular basis and you're documenting it, if you're doing good medical care, the mental cord is not an issue. It's just not an issue. If you saw the notes that doctors were writing, and they're just giving out and sometimes it's not the doctor, sometimes it's Skype, and who knows who it is. And also those licenses, for the most part, aren't that critically important anymore, but they are important in peds, because what if you have a minor, 17-year-old or a 2-year-old? You want to have the parent, one of the parents is a caregiver. There's actually forms that you can fill. They're easy to fill out. I would absolutely still do that, by the way, for your protection and for the parents' protection. I gave a lecture at Disneyland on seizures, and there were about 100 moms in the room, and I asked them, how many of you have talked to a doctor about CBD? One person. So all these other people are putting their kids on medicine. Maybe yes, overall it's safe, but not. There's versions of CBD products out there that are not safe, that are full of heavy metals. You have to be careful. I would say half of the benefit we give our patients is making sure they get good products.
We've noticed with some of our patients that are using the CBD oil that we've had the liver enzymes go up, so then we've had to delay their therapy. They had to get off of the CBD for a while until their enzymes came down.
I've never seen that. Were you guys? Could you be positive? I mean, CBD has just been shown to be hepatic protective. It blocks hepatic damage from alcohol. It decreases cravings for alcohol, cocaine, narcotics. And we see our patients are sick, and a lot of them are referred by oncologists, and just never seen that. I would say it was probably from something else. I don't know how CBD could do it, unless I think I did see one side effect, and this is my concern about using hundreds of milligrams of CBD. Will the P450 system in the liver be the same? I have a feeling it's not. And I'm concerned about these high doses of CBD that people are using. When using whole plant, you get to use a fraction of milligrams. So that's a concern. But I've not ever seen that. Well, it was fun.